Yeah, you can go ahead and share your screen. All right, welcome everyone back to another virtual shadowing session with Hearts for Health. We hope you started off the month of November well, and we're happy to begin the month of November with this session here. We're joined by Dr. Milligan. She's an expert in epilepsy treatment and also the chair of the Department of Neurology at New York Medical College. A few reminders to those who are listening in, especially if you're new, we do have a Q&A towards the end of each of these sessions. So towards the last 15 or 20 minutes, you can ask any questions and we'll answer them at the very end with any remaining time that we have. Just please type them in the chat, the one that you see either below or to the side of the video that you're watching here. That's one thing. Another thing is if you're interested in looking to view more shadowing sessions in the future, we usually operate around a Monday and Thursday schedule, usually at 7 p.m. Central for each of these shadowing sessions. And we'll have them with different speakers and different specialties. Neurology is one of them. Last week we had pediatrics, and we also have dental sessions for our pre-dentistry students. We have some PAs who join us for our pre-PA students. So a wide variety that we offer here. You can either join our listserv or follow us on Instagram to hear from us. For our shadowing sessions, we post our flyers through both ways via email, listserv, or our Instagram page. And to join our listserv, if you're curious, there's two ways you can go about it. Either go onto our website at the very bottom of each of the pages. On our website, any of the pages, you can scroll down and there is a subscription form. Just fill out the information there, click submit, and you'll be good to go. Or you can manually email us, and we will add you on to the listserv. Just include your name and your email. We suggest a personal email. So that's a Gmail or Yahoo account, something aside from your school account, just because school accounts sometimes filter in emails or filter out emails, I should say. With that said, though, if you have any questions for us, let us know. The email to go to, the email to send to is shadowing.h4h@gmail.com. So whether you want to be added to our listserv or have any questions, that's the email to go to. But with that said, Dr. Milligan, feel free to take it away.
Well, thank you so much. And thanks for the opportunity to come and speak to the group tonight. It's absolutely my pleasure. And so definitely ask me anything. Ask me the questions that you have. And I'll be talking a little bit about myself and also about neurology. So I wanted to start out by just telling you who I am and to tell you a little bit about my journey to becoming a physician and becoming a neurologist. So my journey begins here in Albuquerque, New Mexico. And so here you can see where it is in the United States, and that's where I grew up. And I grew up in Albuquerque, I went to public high school there. And the public high school I went to, and like many of the schools in Albuquerque, the graduation rate is about 50 to 70%. And so the conversation in my high school was not so much which college are you going to, but are you going to college or not? And so I did go to college. I went to the University of New Mexico. And when I started college, I was thinking maybe I wanted to go into astronomy. And so why did I want to go into astronomy? Well, I was a big Star Trek fan. So I really like the idea of the undiscovered country, the undiscovered part of the universe, and really learning more about our universe. And I think that is part of just my personality, being really curious about the universe around me. And that curiosity also translates into my job and the work that I do. So I went to UNM, and then while in college, I took some courses and discovered astronomy really wasn't what I was cut out for. There was a whole lot of physics and calculus involved, and it just did not come too easily for me. But biology, I really enjoyed, and it was just seemed to suit my learning style more. And so I transitioned to becoming a biochemistry major and really started to think about being a physician because I loved science, and I really felt like with my life, what I wanted to do was help others. And so those two things together, the interest in science and biology in particular, and my desire to help other people, made being a physician something that I was interested in exploring more. I didn't have any sort of personal experience with family members who were physicians or anything like that. But I was, thinking this was probably what I was going to do. And then while in college, I took a course in communication disorders and learning disabilities. And I became really interested in language learning disabilities. I took another course in aphasia, which are language disorders of the brain, and decided that I'd rather do something that focused on that aspect of medicine, of basically speech language pathology, and didn't involve going to medical school. Because medical school, as many of you know, that's 4 years. It was some college, some medical schools are 3 years, but typically 4 years. And then a lot of training afterwards. Whereas becoming a speech language pathologist is 2 years, and then you're done with school. So there was some appeal to doing that. And also in college, as an undergrad, is when I met my husband. My husband now with 33 years. But at the time, I was really much more interested in trying to get done with school and get on with other parts of life. So I did something else that I was interested in. Oh, here I am. This was my Halloween costume this year. So you can see the tie-in to Star Trek is still big in my life. So anyway, after I graduated from University of New Mexico, I moved to Massachusetts area. And here's my graduate school, Emerson College, which is right in Boston, Massachusetts. And so I went from a very different setting and sort of a desert setting to Boston. Very big change from what I thought was a big city to a much bigger city. And I did my undergraduate degree there. And then I worked as a speech language pathologist for 4 years, mainly helping people who had traumatic brain injuries and had strokes and had aphasia. And it was really rewarding in many respects, but it still wasn't exactly what I wanted to do. And so with that time, that 4-year period of time, and a total of 6 years out of undergrad, I decided that I really wanted to go to medical school and become a physician. And I think that time was really powerful in my life. It was really formative because when I went back to medical school, with that time off in between, I knew it was exactly what I wanted to do. And it actually was fun. Medical school was fun. So I went to medical school in New York, in the Bronx, at Albert Einstein College of Medicine. And I was so happy to be doing what I wanted to do, to have really made that decision. And after working, and if you have a job, you work, it's hard work. Then you go to school and your job is to learn. And it's a totally different pace. And I really enjoyed that. So while I was in medical school, I really liked many different specialties of medicine. And I know you all have access to hearing from other specialists. I enjoyed many different specialties. But when it came time for me to decide what specialty I wanted to go into, what specialty did I want to do residency in, I went back to really wanting to stay interested in the field for my whole life. And I knew that I had been really interested in the brain and how the brain works and what happens when it's not working well for many years. And so it had its roots in me. It was something that I knew I had been interested in for a long period of time, and I would stay interested. And that was one of the main reasons that I went into neurology. So to become a neurologist, you do a residency in neurology, but before you start a neurology residency, you do 1 year of internal medicine training. And so I did my 1 year of internal medicine training in Manhattan. And then after that, I moved back to Boston to do my neurology training. And so for my neurology training, I went to Mass General Hospital and Brigham and Women's Hospital, and that was at Harvard Medical School. I did my training there, and once you're a neurologist in neurology residency, most neurology residents go on to do a fellowship, so subspecialization. And my subspecialty, I chose epilepsy. And epilepsy was a way for me to look into how the brain was working and not working when it would lead to people to having seizures. And that's what I spend most of my time doing is when I see patients is helping people who have seizures. While I was at Brigham and Women's, Mass General, Harvard, I also did a lot of teaching. And so that's really been the bulk of my career for the past 20 years is seeing patients who have seizure disorders and involvement in medical education and teaching medical students and residents and other people about neurology. So a little more personal information about me. So here I am as a very exhausted resident. I was right. It was a lot of work being a resident, a lot of hours. While I was a medical student, I had my first child, my son, and then as a resident, I had my second child, my daughter, and neither one of them want to become a doctor. They tell me they went through it once already, and that was enough. But anyway, it was a big part of they remain a big part of my world, and my husband's been incredibly supportive through all of this work. So here I am where I am now. So after being at Harvard for 20 years, I just recently moved to Westchester, New York, and I work at New York Medical College and Westchester Medical Center. And that was to become the leader in neurology at these institutions, the chair of neurology and director of neurology. And it has led to a different part of my career at this point. I'm still very involved in seeing patients and in medical education, but I'm also growing neurology care to a whole area of the country and really trying to expand what we're able to provide and to take care of people and even a bigger in a systems way. So let me back up and just tell you a little bit more detail about what does a neurologist do. And this information is taken from the American Academy of Neurology. And I'm going to show you how you can all become members of the American Academy of Neurology, where you can see this information as well as a lot of other information. So a neurologist is a medical doctor. A neurologist is a physician. And we have specialized training in diagnosing, treating, and managing disorders of the brain and nervous system. Some of these disorders include Alzheimer's disease, amyotrophic lateral sclerosis, or ALS, concussions, epilepsy, which is my specialty, migraine, multiple sclerosis, Parkinson's disease, and stroke. So chances are that any of you who are listening to this know somebody who's had one of these problems and they've seen a neurologist. So that's what we specialize in. Now, there are also child neurologists or pediatric neurologists. It means the same thing. And pediatric neurologists are neurologists who specialize in all the things that I mentioned, but they also specialize in children and in neonatal and babies. Through adolescence. And some of the conditions overlap and others are unique to the younger population. So child neurologists treat many of the same conditions found in adults, such as migraine, epilepsy, stroke, and Tourette's, and are also trained in conditions relating to neurogenetics and developmental problems. So we diagnose problems in the nervous system. And so this is again from the AAN website. We're highly trained. Yes, we do a lot of school, we do a lot of training. And the nervous system really controls the entire body. What is more important in the body than the brain? Basically, the function of everything else in the body is to support the brain. You can't transplant a brain. And so it is complex, and many people who go into this field are actually drawn to that complexity because we need to understand things that many other physicians don't have that training in and help people who have concerns about the nervous system or diseases in their nervous system. So we do very thorough history, getting information from the patient. Sometimes I feel like a detective getting information from the patient and asking people who know the patient, getting information from them. So very thorough history. And then the physical examination that we do as neurologists is very detailed. It's a detailed neurologic examination. And I'm going to tell you a little bit more about that because it's such a big part of what all neurologists do. So we do a mental status testing, vision testing, speech, strength, sensation, coordination, reflexes, and how a person walks, or what we call gait, basically how somebody walks. So even though in medicine we have all this great technology, the neurologic exam is not replaceable by any technology. So many people who choose to go into neurology really enjoy that part of it about being a neurologist. Then in so many ways, we're like an old-fashioned doctor that we examine our patients and we can't rely on tests. The tests help us with the diagnosis, but the test cannot give us a diagnosis without the history and the examination we do. Some of the tests that we do CT scans, MRI scans, so just ways of imaging the brain, spinal cord. We also do a test that I do a lot of, and that's the EEG, electroencephalogram. The EEG involves, we put electrodes at various places on the head, and we measure the brain waves. That's right, we measure the brain waves. We can actually detect the brain waves. We can tell when somebody is concentrating, tell when somebody's sleepy, we can measure when they're asleep, and then we can measure different ways that the brain waves may go wrong for different disorders of the brain. We do another kind of electrical test that's called nerve conduction study, or EMG. And this time, we actually deliver little tiny electrical shocks to the nerves in the body, and we measure how well those nerves are working. So the nerves, for example, some people get a numb hand at night. You might wake up and some of your fingers are sort of numb and tingly. Well, most of the time it's because of that nerve that goes in your wrist called the median nerve. And sometimes people have it pressed in the carpal tunnel of the wrist. Well, we can measure how that nerve is working by stimulating it and measuring how well it conducts. Because the nerves in our arms and legs are basically like the wires that run our electrical things. And so we can measure how well that wire is working. We also put a needle, a tiny, tiny needle, into the muscle, and we can record how well the muscle is working to diagnose things, problems that involve the nerves and the muscles, like ALS, which I mentioned before. We do some procedures like the lumbar puncture or spinal tap, where we insert a needle in between the bones in the lower back to sample the spinal fluid and run tests on that fluid. But we're not neurosurgeons. And a lot of people get this confused. What is a neurologist? They'll say, I'm a neurologist, and they'll ask me if I do surgery. No, a neurosurgeon does surgery. So if you're interested in the brain and the nervous system, and you really want to be a surgeon, then neurosurgery is a good profession to look into more. Now, although I don't do surgery myself, I collaborate very closely with neurosurgeons because some of my patients do need surgery, and we work together as a team where I help guide where that patient needs the surgery for the neurosurgeon to perform. A lot of teamwork in medicine, and in neurology, one of our big areas of teamwork is with neurosurgeons. I'll just mention that there are some specialists in neurology, subspecialty trained, where they do procedures, where they do what we call endovascular procedures, and they may put a small catheter through the arteries all the way up to the brain and treat different vascular malformations in the brain, or remove blood clots that may be part of a stroke. So there is a way to do very, very complicated, intense procedures as a neurologist by going into that subspecialty. Many neurologists do procedures like injecting Botox or other nerve blocks to help people with pain syndromes. So here I told you how you could join the AAN. So here you can just scan this QR code and it will take you to the website where you can register. And as a student, you register for free, no cost, lots of resources, and you get information about things that have to do with being a neurologist and a lot of opportunities to seek out other mentorship with neurologists. So if anything I've said so far is interesting to you, definitely register. It's free, no downside to doing that. So I want to tell you a little bit about the neurologic examination because I'm going to show you an example of a kind of some patients that I might see in my day-to-day work. So the neurological evaluation, it really is something we do on every single patient after we do the history. And so when we talk to a patient and we hear what their problems are, we find out detailed information about it. And then we think, what part of our neurologic examination do we want to do to see whether our hypothesis or theory about what's wrong with the patient is true or not? And so we do the examination, and that helps guide our hypothesis and guides our testing. When we do the history and we do the examination, the next step as a neurologist is what we call localization. Because the nervous system is basically from head to toe. You have the brain and all the different parts of the brain, the spinal cord, the nerves, and the nerves that go all the way to all the muscles. And we're thinking every step of the way, is this person's hand numb because they have carpal tunnel syndrome? Or is it numb because they had a stroke or something else in between? So we want to use our history and the examination to pinpoint exactly where in the nervous system the problem is. And that's right, that's our detective work. This is another reason that many people go into neurology because they have experienced shadowing a neurologist and they see how by doing this history and examination, we can figure out exactly where the problem is. And once we know where the problem is, then we do testing because where the problem is could be due to a lot of different causes. And in order to find out what causes the problem, we do different tests. So localization creates our differential diagnosis, and then that leads to our tests. So this is what I tell my students. So these are for medical students. So for you, you don't need to memorize these categories, but when you're a medical student, you will. You'll need to memorize these. And this is what a neurologist, every time we see a patient, we write a note about our neurologic examination and we break it up into these categories. Mental status, and that includes both the psychiatric and the neurologic components of how people remember, how they feel, how they act, how they behave, their visual spatial abilities. We look at the cranial nerves, which are all the nerves that go to the head and the neck. Motor exam is how strong somebody is in all the different parts of the body. Sensation, how they're feeling, different things, whether that's just the sense of touch or temperature, pain, vibration. Proprioception, are they able to tell where their body is in space? We're able to test all of that. We look at coordination. And so coordination, you may have seen this on a movie or maybe you've seen a doctor do this. One of the main tests is we have somebody touch their nose and then they reach out and they touch our finger and they go back and forth. And we're testing their coordination. That's a common coordination test. And we watch their gait or how they walk. And we check their reflexes. With our reflex hammer, we tap on, for example, all of you have probably had your knee reflex checked in the doctor's office. So we have many reflexes in the body that we can check. And that all gives us information that allows us to localize where the problem is. So our mental status testing, we're basically testing all the different parts of the brain. And so here from a textbook, you can see a diagram of the brain. And here's the frontal lobe of the brain, which is right in back of the forehead, the temporal lobe of the brain right inside the ears, the occipital lobe of the brain in the back. And each part of the brain has different functions. And so we have very specialized tests to test each of those areas of the brain. This is the left side of the brain. And so the left side of the brain is where language is located. This is something I've always been really interested in, aphasia. And that's when you have a problem that has affected the language comprehension area or the word formation area, Broca's area and Wernicke's area. So people can have problems when they have problems in the frontal lobe with their attention, their mood, their behavior. Executive function means organization, planning, judgment, movement, because the left frontal lobe moves the right side of the body, and language in the left hemisphere. So the frontal lobe, we neurologists, we have little jokes, little things we say about the frontal lobe. Like if somebody is behaving kind of strangely, we'll say, oh, you know, they're acting very frontal. The frontal lobe is the last part of the brain to become fully developed. It doesn't become fully developed until people are in their 20s. So let me tell you, my children have heard many times they have to listen to me because my frontal lobe is fully developed and theirs isn't yet. So I have better judgment, reasoning, etc. So, but you can think about yourself, right? When you're younger, when you're a teenager, do you make the best decisions? No, your frontal lobe's not quite developed yet. And there's a lot more risk-taking behavior that can also happen because you don't have that executive functioning. And some people, unfortunately, never develop fully functional frontal lobes. Sometimes people have damage to them, like from a traumatic brain injury, where they can start to have problems in this area. And then it's also the part of your brain that isn't working so well when people are depressed. And so if anybody's had depression or you know somebody who's depressed, just know that they're just not able, the brain just is not working normally. That's one of the reasons it's so important to seek treatment for depression, because the depression really, if we look at different scans of the brain, we'll see that there are parts of the frontal lobe that are just not functioning normally. But once depression is treated, they go back to normal. So just another important thing to kind of keep in mind. So frontal lobe disorders, I mentioned people have poor judgment, reasoning, organization, planning, and concentration. They can have apathy, depression, disinhibition. That is when people do things without, sort of like, didn't you think about that before you said it? And our frontal lobes become disinhibited under substances like alcohol, causes a lot of disinhibition. Does not allow the frontal lobes to work as normally as they could without alcohol. If there's a frontal lobe problem, again, you have the other side of the body, contralateral, will become weak. And if it's in the left hemisphere, you have Broca's aphasia. Aphasia has been in the news a lot lately because of a politician who has aphasia. And so aphasia is not a problem with intelligence, but it's a problem being able to put your thoughts into words really easily. That's a Broca's kind of aphasia. Or people can have other kinds of aphasia that causes more trouble understanding language. But again, not a problem with intelligence, but a problem with communication. And the temporal lobe of the brain, there's a very famous figure in history, and that's HM. And HM was a patient who had both the memory centers of his temporal lobe removed. He actually had them removed because he had epilepsy, a seizure disorder, and they were trying to cure his epilepsy by removing the parts of the brain causing seizures. They didn't know at the time that if you removed both memory centers of the brain, you would create permanent short-term memory loss. And so HM is talking to one of the researchers who worked with him over the years. And she said to him, "Do you know what you did yesterday?" "No, I don't." "How about this morning?" "I don't even remember that." "Can you tell me what you had for lunch today?" "I don't know, tell you the truth." And so he had memory loss because of this surgery. But neurologists see a lot of people who do have short-term memory loss. For example, people with Alzheimer's disease, they start with having short-term memory loss. People can have different infections of the brain and the temporal lobes that cause short-term memory loss. And then people can also have short-term memory loss if there's been any problem in this part of the brain. a lot of people worry about their memory. And so they may go to a neurologist, and one of the jobs we do as neurologists is we figure out whether they're having memory problems because of the memory itself and a disease that's affecting the memory, or are they having memory problems that feel like memory problems, but they're really a problem concentrating. Because if we can't concentrate on something, we can't remember it as well. And it's really common to have problems concentrating if people are under stress or haven't slept well. And so neurologists figure this out. We figure out why people feel like they're having trouble with their memory, and some of the things can be treated. So that can be a big part of what we do. Here is the MRI scan of this patient, HM. And so here is, I'll just show you on this bottom left, is a picture of his brain. You can see the ears on either side. So it's sort of like we're looking right at him, peering through to the hippocampus, which is the memory area of the brain. And that's the area where he had surgery. So if we look at the brain in another way, kind of cross section, axial here, the ears are on either side and the eyes are at the top, sort of cut off here. And you can see all of this black is where he used to have his brain, and it was removed with surgery and caused these problems. So I mentioned before that neurologists work really closely with neurosurgeons. Neurosurgeons never ever want to do this. This was at the point it was done, we didn't know this would happen. But now we really try to avoid this happening, and we'll work together to make sure that we understand more about the brain and where the surgeon is operating to help prevent any problems. We also test the parietal lobe of the brain. So I told you about the memory and the temporal lobe, the judgment and the frontal lobe, and the parietal lobe is sort of back here on the sides. That's where our sense is, our sensation, how we're aware of personal and extrapersonal space. Also, where reading and writing, a lot of mathematics are located. But if there's damage to the parietal lobe, especially if the damage is in the right parietal lobe, people can develop really interesting problems. And that is something that's called visual neglect, or left neglect, if the problem is in the right hemisphere of the brain. And so what is left neglect? This is another thing that neurologists know a lot about, all of these different problems that can occur when parts of the brain are damaged. But if you haven't heard about this before, I'm about to blow your mind, because this is really interesting, that people lose their ability to know that they have a left side. So here's a sample of somebody writing, and you can see they haven't used the left side of the paper. They don't know it's there. It doesn't exist. And then you can see on the bottom is a passage reading, and somebody's asked to read aloud, and they start reading here way over on the right and never read anything to the left of this double hash mark. Here you can see somebody who we've asked to bisect all the lines. So take these lines and put a line so you make it, cross it right in the middle. And you can see these are completely missed on the left. And even the ones that the person does see, their appreciation of the line is truncated. They don't even know that the line is over here. They think they're right in the middle when they put that blue mark there. And that translates even to how people care for themselves. So, for example, men may only shave the right side of their face. They don't even do the left. Or people get dressed and they don't dress the left side of their body. And here's a patient who was asked to copy. So here's the model. We say copy the clock, copy the house, copy the flower. And you can see how the left side of these images is missed. And then here's drawings, and you can see how there's not as much detail on the left. And so when the brain is damaged, this is one example of what can happen. And sometimes, depending on the cause, this can get better to a certain extent. But we also work very, very closely with rehabilitation experts to help people learn how to compensate for problems like this. I mentioned that we test the cranial nerves, which are the nerves in the head and the neck. These are examples. If you go to medical school, you're going to know all of these. Every medical student, every dental student, many other healthcare professionals need to memorize this. And we're able to test each and every one of these, and it helps us localize where the problem is. And then I wanted to show you one of our favorite tests in neurology, which is what we call the plantar reflex. And this is when we use a tool to stimulate the bottom of the foot. And in babies, when we do that, this big toe goes up and the other toes spread apart. Once you're not a baby anymore, this doesn't happen. What happens is your toe goes down and your toes curl, or you get really ticklish and you pull your foot away. But we can test if there's a problem in the nervous system, because if there is in the central nervous system, in the motor tracts, the reflex becomes abnormal again. And that's what we call a positive Babinski sign, or the upgoing toe. And that helps us localize that there's a problem with the upper motor neuron in the brain or the spinal cord. So that's one of the tests that helps us localize as neurologists. And here is an example of a baby who has a positive Babinski sign, which is normal in a baby. So that's what we see, positive Babinski sign. And if we see that in somebody who's not a baby, it's abnormal, and it lets us know where to look in the nervous system. It's a clue. And so again, I talk about being a detective, putting the clues together. And that appeals to a lot of people who do go into neurology. That idea of putting all the clues and putting the pieces together to figure something out. And then the good thing about neurology now is we have more treatments that come out every year than any other specialty of medicine other than oncology. So good thing there's a lot of new cancer treatments coming out, but second to that is neurology. So that's different than it was 100 years ago, when the job of the neurologist was to figure things out, but then there wasn't a way to cure or treat diseases. Now we have cures or treatment for everything, and we become experts in that as well. So the sensory examination is part of our neurologic examination. And we can, again, we do different things. We can do the sense of touch, vibration, joint position, temperature, pinprick. This allows us to localize, to figure out where in the nervous system the problem could be. We do a test called the Romberg test, where we have somebody put their feet together and close their eyes. If you've ever seen one of those drunk driving tests on TV, that police officer is doing a neurologic exam, a little mini neuro exam that includes the Romberg test, because one of the areas of the brain that alcohol affects is the balance center of the brain, or the cerebellum. And so when people are really intoxicated, as soon as they put their feet together, they lose their balance. Now, we also test the sensory system, because if they put their feet together, but they keep their balance, we have them close their eyes. And if they lose their balance, that helps us know that they have a problem with the sensation in the body. And again, is another clue to help us localize. We watch people walk. We watch people walk all the time. Neurologists are experts in analyzing people's gait. And so I would driving around with my family, and we'd see somebody who was having some trouble walking, had a different gait. And my kids would always say, "Mom, what's wrong with that person?" And I'd say, "Oh, it looks like they have Parkinson's disease, or they had a stroke," or, so there are different ways people walk that go along with different disorders of the nervous system. And I teach my students to not only watch people walk, but listen to them walk as well. And so again, this is part of the detective work, observing, listening. And you all know if you live with other people, you don't even need to see them. You can hear them and you can recognize who they are by how they walk. And so we can recognize different problems in the way people walk and in different ways that we observe. So there are different parts of the gait cycle that, and again, if this is something that appeals to you, like how do we actually walk? What muscles cause our foot to and our leg to move? A neurologist study this. There's other experts in the healthcare field who study all these parts of walking and diagnose and help people with walking, difficulty walking. And I mentioned some of the gait abnormalities that we see. So the hemiplegia, that means weakness on one side of the body, and that has a very specific way that people walk. It's usually from a stroke. So that is something that you'll see in the course of a week if you observe, because stroke is so common. You'll see somebody who one side of their body doesn't seem like it's moving completely normally. With Parkinson's disease, we see people have sort of a stooped and shuffling gait. With cerebellar ataxia, that's how people walk when they're intoxicated, really wide-based, feet wide apart, kind of stumbling, losing their balance. A foot drop, if you've ever crossed your legs and then you get up to walk and your leg gives out on you, you have a foot drop. That happens from compressing your nerve on the side of your knee. And it's temporary in that case, but there can be other reasons that people have that more permanently. And then the sensory ataxia, some people lose their sensation in their feet. Having diabetes is one of the ways that people can lose sensation in their feet. And when you don't have sensation normally in your feet, you don't know where they are when you're walking. And so it has a specific look to it as well. So I went over with this with you. Part of the job of a neurologist is we do the history, we do the examination, we localize, we come up with our differential diagnosis, which is our hypotheses of what the cause is, and then we do the tests to come up with a diagnosis. When we think about what the disease could be, we look at how quickly the disease comes on. Does it come on suddenly? 1 minute, somebody's completely normal. The next minute, they're not. That's what can happen in a seizure, for example, or a stroke. Does it happen more slowly over weeks or months? And that's what we call subacute. Or has it been going on for a very long time, maybe years, and that's chronic? And so it's how quickly the symptoms accumulate or occur. And then our localization, whether we can localize it to one very specific part of the brain, or it seems to be more diffuse and involving a lot of different parts of the nervous system. And then we can fill in this box with our possible diagnoses. And so, for example, if something happens all of a sudden, and it's just the arm becomes weak, or somebody has slurred speech, we worry about a stroke, a vascular problem. And so hopefully some of you have heard of the campaign to stop stroke, to think fast, face, arm, speech, time, right? You have to, if somebody has sudden facial weakness, slurred speech, arm weakness, call 911, right? So that's an acute focal problem. And a subacute focal problem would be something that's in inflammation in the brain or a spinal cord, like multiple sclerosis. Or if it's been going on for a long time, it might be a slow growing neoplasm or cancer. If it seems to be involving many different parts of the nervous system, it could be that there's a problem with some other part of the body. Like, for example, if the blood sugar is too low, people will all of a sudden become confused, but it's not just one part of their body that's weak. They're sort of weak all over. So that would be a metabolic acute cause. It could be an inflammatory cause that has affected many nerves in the body, an autoimmune process, if it's subacute and diffuse. And then if it's diffuse and chronic, sometimes it's a neurodegenerative problem where it may be something that is accumulating over time and getting worse. Like, for example, ALS can happen over years, and it involves many different parts, both arms, both legs, speech. It can be more diffuse. So now that you've gotten an intro into neurology and what we do, here you go. Here's your first patient. We're going to go through a patient together. And so this is a 49-year-old woman. She has a past medical history of obesity, hypertension, hyperlipidemia, which is high cholesterol. And as she's watching TV, she has the sudden onset of left-sided weakness and slurred speech. It lasted 10 minutes. She went to the emergency department and had some tests, and she was discharged home with a diagnosis of anxiety. Now, you all have been paying attention to me, and you're like, wait a minute. You know, she had slurred speech and focal weakness, and it's sudden onset. What do you think it was? Did you say a vascular cause or maybe a stroke? Or if it went away, we call it a TIA. And you would be exactly right. Good job. So, you know, I have to think about what tests did they do, but this is where the history and then really thinking things through is much more important than tests. So as she was leaving the emergency room, she had another episode of left-sided weakness. And then 2 days later, while driving home from work, she had recurrence of her symptoms. So this is a video that is posted because she was on the news, so it's easily available on the internet. So I don't think there's any HIPAA problems here. There's no confidentiality problems here, that she shared this herself, and it's already out on the internet. So here she is, she's recording herself. Now, as I play the video, I want you to make observations. What do you notice? What do you see? And even before I play the video, you can be looking at her face, thinking, you know, is there anything different from one side to another? And these are the observation skills that we use in neurology. So I'm going to play the video. I'm not sure whether the sound will work for you all or not, but that's okay, because you can just make observations even if you can't hear her speaking.
And sensations happening again. Smile, Lisa. Smile.
So she's trying to smile.
So tingling on the left side.
Tingling on the left.
On the left side. The doctor said to breathe in, breathe out, manic distress.
And her speech is a bit slurred.
So now I'm taking a picture for an example of what happens.
So this is all a selfie video.
My hand is hard to lift up.
Hand is hard to lift up.
And she touched something, took my nose.
It's hard for her to touch her nose. So now you can sort of look at, think to yourself, what did you notice on this video? And I'm just going to play it again, and I'm going to just take away the sound in case it is audible. And think about the observations you made. So I'm going to say, just looking at her face, and this was something you could see on the still, is that her eyes are asymmetric. Her left eye looks different than her right eye. Right? It's not as open quite as much. And then the left side of her mouth isn't moving normally. The right side has more normal movement to it. The right side is completely normal, Whereas as she's talking, the left side is not moving quite as well. And then you can also see that change in her eyes too. So she has a left facial droop, left facial weakness. She's also talking about how it feels different, the sensation is different. And when we listen to her speech is slurred. Later in the video, when she lifts up her left arm is lifting up very slowly. Her whole left side of her body is moving very slowly, very clumsily. And because her left arm is weak, she's having trouble moving it normally. So now we have basically, she's done a lot of the neuro exam in front of our eyes. If she was with us, we would be doing a lot of the things she's doing, asking her to smile, to look at her face move, asking her to move her hands, looking for weakness, testing her sensation, listening to her speech, and checking how her tongue is moving, doing all these parts of the neurologic examination. And so we know this is not anxiety. Anxiety does not cause these problems. The doctors who saw her in the emergency room, they were at a disadvantage because her examination at that time was normal. It was TIA, so she had gone back to normal. So you made some good observations. Here are the things that I pointed out. She is wide awake, so she seems to be thinking normally. Her speech is slurred, what we call dysarthria. She has a left facial weakness, and her left upper extremity is weak, her left arm. So she had only a small stroke, and she made a great recovery. So good news to that story there. So let me just go ahead, and I'm going to show you one more video before I end and ask some questions. So I'm going to just go ahead and jump forward to that video. Okay, because I wanted to share with you my subspecialty. And my subspecialty is epilepsy, or people who've had seizures or suspected seizures. And so this is something I again, want to just share with you, that it's really common to have a seizure during lifetime. 1 in 10 people will have a seizure in their lifetime. And 1 in 26 people in their lifetime will develop epilepsy, which is a tendency to have recurrent seizures. So if somebody has a seizure, the best thing to do is just make sure this environment is safe. We can try to, just help somebody lie down, help them lie on their side, put something under their head to prevent injury, protect them from any dangerous things in the environment, and stay with them until they come out of the seizure, which usually only lasts a couple of minutes. But important to not put anything in the mouth, which can really hurt the person, damage your teeth, or injure you. It could actually cause them to aspirate. So don't put anything in the mouth, and don't hold the person down or try to restrain them in any way. This, let me just pause this for a minute. This is a reenactment of the most common kind of seizure that adults have. And so I wanted to play this for you. And again, I'm not sure whether you have the sound or not, but the sound is not important. It's just a reenactment of an actor showing you what can happen with the most common kind of seizure that adults have. So he's in the middle of the presentation and stops. And you can see that he just stopped doing his presentation, was sort of staring into space, has those mouth movements and hand movements. And the other actors are demonstrating how you help somebody who's having this kind of seizure. And so everybody in the environment staying calm. And people can have a seizure and they still have their eyes open, but their brain isn't functioning completely normally. And so she's just making sure that he's safe. Because although he's able to still walk, he's not completely thinking through everything. And so when people have seizures, the reason probably many of you don't know how common it is that 1 in 26 people have epilepsy. The reason is because most people don't have seizures when they're taking the right medicine. So it's only a small part of the people, about 30–40% of people who will still have seizures. So most people who have epilepsy, they take a medicine, they don't have any seizures. But when the medicines don't work, we have different types of surgery that we can do. And so this is something that I'm very involved in my work, is helping, first of all, understand how the medicines work in the nervous system, picking the right medicine for the patient. But if the medicines don't work, we have ways to do brain surgery, including inserting lasers into the brain to treat the part of the brain causing seizures. We do what's called laser ablation, working with a neurosurgeon. So that part of the brain is burned by the laser, so it can no longer cause seizures. We can put a computer in the brain. This is a computer in the brain. It's in the skull, actually embedded in the skull, but it has electrodes that sense when a seizure is starting and stimulate the brain to stop a seizure. We have electrical stimulation that can be go to the nerve in the neck, which then that electrical stimulation travels back to the brain. And we have stimulators that can go into the brain itself and stimulate the thalamus of the brain. So these are some of the different ways that we treat epilepsy. So I showed you two very common things that neurologists treat. One is strokes and time is brain, because we have a lot of treatments that we can only use when somebody gets to the hospital very, very quickly. So think fast, stop stroke, face, arm, speech, timing, get them right to the hospital. And then epilepsy, which can be subtle, like I showed you in that video. And so a lot of what we do in any area of medicine has to do with public education. And so that people can recognize, oh, that odd behavior, that could have been a seizure. And maybe that person should see a neurologist, we'll give them a medicine, and good chance that they'll stop having those seizures. So last slide. I like this one because it highlights some of the things that I've been emphasizing today as a neurologist. It's our power of observation. But that power of observation, it's not what you look at that matters, it's what you see. That power of observation is something that, if you work in healthcare, is very, very important, no matter what the specialty, but especially, I would say, especially important in neurology. So I'd be happy to answer the questions that you have now. Thank you very much.
Absolutely. Thank you so much, Dr. Milligan, for such a great presentation. A lot of times students really love to see like just an example of a case. And this was such a great presentation to showcase that. Really helps them get a great sense of neurology. And I think this is our second session on the specialty. So we're very, very glad to have you. We can maybe take 15–20 minutes to maybe answer questions if you don't mind. Our first one, and I'll go through the order that we received them. If you have any other questions for those listening in, you can write them in the chat, but we might not be able to get to all of them, unfortunately. Our first question, though, is what is your least favorite part of the neurology specialty? I know that you've talked about a lot of the highlights, but what would you say is your least favorite part?
My least favorite part, well, my least favorite part is when we have incurable diseases. That's my least favorite part. But I'll say on the other side of it is that there are so many advances that there are diseases now that don't have a cure that will have a cure while I'm still a neurologist. And definitely for people who are younger, you will see these diseases that don't have a cure have a cure. And then the other part that I'll also say, although it's my least favorite part, I do find it very rewarding to help people even when there isn't a cure. Because, for example, one of the diseases we don't have a cure for now is ALS. And I mentioned that a couple of times during my presentation. We have some treatments, but we don't have a cure. But there's a lot that we can do as physicians to help people even when we're not curing. right? So really comforting and supporting and treating symptoms. And that's all part of what I do too. But I really look forward to continuing to see more cures come out and more treatments in neurology.
You talked about the difference between where you train as a neurologist and what a neurosurgeon would train in, between consultation and surgery. And you mentioned that you do communicate with them from one specialty to another with patients that require surgery. Are there any issues that sometimes come up when you are getting in contact with another provider?
I think that collaboration and teamwork are so important. And the very, very best patient care comes from really collaborative, good teamwork. So that is key. It's no longer, medicine is no longer the way it was centuries ago, where it was like one doctor, seeing everybody and doing everything themselves. That just doesn't happen anymore. You always work in teams, and you want to try to work with a good team and focus a lot on that. So now you think about when you've been in school and you've been put into teams. You all have had good teams and you have had bad teams. That's just being human and working with other humans. But it does take some work and some skills. And that's what happens in medicine too, is that we work really hard to form good teams. And, it's not just luck that people work well together. It really takes conscious effort, and it's part of training. And part of training in any kind of health profession these days is working on your teamwork and your ability to work with other specialties.
You talked about starting a family. You had your first kid in medical school, your second in residency. So a student is asking that they've always thought of having their family after finishing school, after wrapping up everything to do with residency and medical school. Would you say that's unreasonable or an unnecessary sacrifice in pursuing your dreams in medicine? Would you have rather, in terms of the timeline, delayed it outside of your training?
I think that there's, the same timing is not the right timing for everyone. For me, it worked out really well. It worked out well for me because I have a very supportive husband. And so he did a lot when I was on call overnight. He was solo with the kids. And, that was part of our partnership and our teamwork that worked well. I think anytime that you have children, anytime in life, it's extra joy and it's extra work. And so if you wait until after training, there's still going to be things that you're pursuing in your life that make those pursuits more challenging. So it does add challenge. It adds it's amazing. I love being a mom. But I think that it can be challenging as a student, it can be challenging in training, but it can also be challenging when you're done with your training. And so really it's a personal decision, but it really does require that support. And so for us, we didn't have any family nearby. It was my husband and then a nanny, and a great nanny. But people do it all sorts of ways, but you can't do it alone. So you've got to have that support.
Absolutely. Our next question is just about your normal work week. So being in academic medicine, I'm sure that would involve some research, some teaching. It's a good variety. Could you take us through what a normal week looks like for you at work?
Yeah, sure. And that's changed over the years in academic medicine for me. But first of all, I'll say one of the things that I love about academic medicine is the variety. So I do not have 2 days that are the same, and I don't have 2 weeks that are the same. There's just so many different things that you can do. And that pursuit of differences and the clinical education research and working with other people that were interested in those things, that was why I went into academic medicine, and to work with people who are in training, to work with medical students and with residents. I didn't want to be in a job where I showed up every day at 8 and I left every day at 5, and I did the same thing in between 8 and 5. I like the variety. So today, for example, at 7:30, there's a teaching conference for the residents from 7:30 to 8. And so I attended that conference. And then after that, I saw patients in the outpatient setting and worked with a resident. And so we saw patients together and I did some teaching with her and did that until about 1. Then I had a lunch break and I was driving back to the hospital to do some other work. So it was a really nice day. I got my lunch, parked my car, had my lunch, talked to my husband on the phone while I was having lunch, little break. And then I worked on some projects. I had some different meetings. I have because I'm the chair of the department, I have some different projects I'm working on. And one of those is working on diversity, equity, and inclusion. So I had a meeting with the vice chancellor in that. We were talking about some efforts that were to work on. And there was another conference, a neuroradiology conference, another meeting talking about a new system of how to care for patients in the hospital. And then I spent a little time working on what I was going to talk to you about tonight. So that was my today. My tomorrow will be totally different. But to sum it up a bit, I see patients, outpatients. I also work in some weeks out of the year and I see inpatients. And so I spend my time in the hospital. I see inpatients who have epilepsy or people who have other neurologic problems that are admitted to the hospital. I teach at the medical school. So I did a lot of teaching at Harvard Medical School and I'm starting to do a lot of teaching at New York Medical College. I'm also the residency program director. So I do a lot of teaching with the residents and I do a lot of administrative work too. Different projects that have to do with improving education or improving patient care.
The medical students who are in school today, what's the best piece of advice that you would give them? What's something that maybe they're overlooking that you would find useful to put more emphasis on?
For medical students, all
Yeah.
right. If you're a medical student today, there's a good chance that you're tired and stressed and you wished you had more time to do something else important in your life. And so I think that taking care of yourself is number one, all right? To really think about establishing healthy habits and a healthy self-care. And that's important because those habits stick with you. And people generally come into medical school with pretty good habits and pretty good resiliency. But then you get so busy and there's so many things that you need to do that sometimes those things that are actually really important can get neglected. And so I just encourage you to really keep focus on that and keep trying to do what you can to keep those healthy habits. Because when you become a resident and then when you become an attending, it's easy to stick with those bad habits. So that's one thing I'll say. So, do try to continue with your exercise routine. Take time to call the people you care about or to write them a short note. And when it comes to the stress that goes along with trying to learn such a large volume of information, just appreciate how much you've learned. You've learned so much, you're going to keep learning. One thing being a physician, you constantly learn. You're constantly learning. There's not like you finish and you're done. So to appreciate how you're learning things that are going to help you take care of somebody, and they're going to help you treat other people, but you're not going to be able to do that well if you're not healthy yourself. So that self-care, I think, is important to emphasize.
Absolutely.
Including, remember, treat anxiety and depression. It's so common and it's treatable. Mm-hmm. And there's a lot of resources out there. So don't neglect it, get treatment. If you have a friend you think is suffering from anxiety or depression, remember that one of the symptoms of depression is that it's hard to motivate yourself. So that's one of the things being a physician, we're part of a profession. Being part of a profession means that we take care of one another. So you can start working on that aspect of professionalism too.
And a quick question to segue off of that topic. A lot of people now are much more open about talking about anxiety, depression. It's just much more of a prevalent thing. From your perspective, from your years of training and practicing, do you feel, or do you think the number of people who deal with anxiety or deal with depression has been constant, or has it been increasing due to things like social media um, and other triggers that might cause that? Has it been always the same proportion, or is it just something recent?
I don't know, but I will say it's incredibly common, and a lot of people don't realize how common it is. And so, having worked with a lot of medical students, if I'm with a large group of, like, say, a group of 15 medical students, and we do an anonymous survey, who has depression, who has anxiety, the things that go along with that, it's basically everybody or almost everybody. And it's just so common. And I wouldn't have guessed, people maintain, they kind of have a certain exterior. And that, and you mentioned social media, that's when it comes in, everybody posts the great things on social media. But I think what has happened is that now people know that, when social media was first getting going and people would only see the happy posts, and you think, it just makes you feel bad because your life isn't all happy. But now people know that's all false. That's all sort of curated and false. That's not real life. But I still think that that it can add some stress. So again, being aware of yourself, that self-awareness. If you find there are certain things that trigger you and make you think negatively or make you feel down, and it involves social media, I would just limit it. Just, recognize that that's not good for you. There might be other aspects of social media that really are encouraging and uplifting, and, you want to do more of that. I do think that the social isolation that went along with COVID made things worse, because we human beings, we are social people. We want to be together with people. We want to give each other hugs. That's who we are. That's part of being human. And so, finding ways to really stay connected with people in real ways where you can be yourself, where you can feel that you can bring your whole self to that social situation, I think is really important.
Absolutely. Absolutely, 100%. I think we'll go through one more question before we wrap up today's session, and that's going to be about the differences in demand between neurologists and neurosurgeons. Is there much of a difference in terms of job outlook and future demand for the profession between those, like, consultation and surgery specialties?
Both are fields that are very much in demand. I can speak more about the demand for neurologists, which is one of the number one types of physician in demand. There's a shortage of neurologists, and there's projected to continue to be a shortage of neurologists. And so, but basically, if you're any kind of physician, you have job security. Yeah, so that's a good thing about being a physician. It may not be the city you wanted to live in, but you'll be able to work. Neurosurgeons are also in demand, and it's highly specialized, and you want your hospitals to have neurosurgeons available to them, because it can be an emergency. So also an in-demand specialty. The hours worked are different, but once you're in a specialty as a physician, there are ways to adapt your hours. So not every neurologist works the same hours or as many hours, and it's the same for neurosurgeons.
Well, I think we'll wrap up today's session with that point. For our shadowers, just a quick note before we do close. To earn credit for your attendance today, we prepared a quiz, 10 questions, and you must answer 6 or more out of those 10 to receive your certificate. Again, for credit of attendance, we have these certificates per session, and you can collect them for documentation of your virtual shadowing hours. This quiz, I should say, It's posted now in the chat box and also available on our website. If you go onto our website, go under the virtual shadowing page, scroll a little down, and you'll see a Monday and Thursday quiz. Since this is going to be the Thursday quiz, you'll see on the right-hand side, it's going to be something like Thursday quiz, Dr. Milligan, November 9th, which is going to be the due date. It's going to be specifically at 11:59 p.m. Central next Wednesday, November 9th. And like I said, after passing that quiz, you'll receive your certificate. It's going to be sent to the email inbox of the address that you list on the quiz. So be sure to list one that you're comfortable with. We highly recommend using a personal Gmail or a personal Yahoo account because your personal emails tend to not filter these kind of emails as much. And as always, feel free to reach out with any questions you might have. Just in case you don't find your certificate either in your inbox or spam folder, you can always reach out to us and we can retrieve it for you. And then next week, we're going to be joined by Rashada. She is a board certified PA in psychiatry. We're going to see her at, as always, 7 p.m. Central on Monday, November 7th, I should say. And again, if you'd like to follow us to learn or tune in to more sessions, we have our Instagram and we have our listserv. Both are great ways to stay in tune with us. And for Dr. Milligan today, can we have some thank yous in the chat? She did such a wonderful presentation for us. She gathered this and she took some time to not only join us today, but also prepare her presentation. So we really appreciate your time. I'm sure a lot of people have not only learned about neurology today, but caught somewhat of an interest at the very least. And for those who have, maybe diving into the specialty a little more with further shadowing, maybe local to you, some in-person shadowing might be a great idea. Do you have any other, just a last question, do you have any other pathways outside of shadowing that people can get more involved and take a step, dip their toes into neurology, see a little more about what the specialty is like?
Yeah, I would think that there are a lot of ways. If you look for neurology, neuroscience in your community, you might find opportunities there. I'll also highlight that there is a great blog called Neuroscience for Kids. And Neuroscience for Kids is run from University of Washington. But if you just Google Neuroscience for Kids, in that newsletter that comes out every month, they always have a list of different programs, different opportunities. And the author of that is also really great mentor. And you know, that's in Seattle, but there's a network of people who are really interested in helping people who have similar interests. So I think through Neuroscience for Kids and then American Academy of Neurology, I would definitely seek out those, and you'll find more resources through those methods. Absolutely, two great resources, and I'm sure for those listening, hopefully you'll dive into those if you got somewhat of an interest from today. Like I said, we do have shadowing sessions moving forward next week, so we look forward to seeing you there. But for now, hope y'all enjoy the rest of your week, enjoy a good weekend, and we'll catch you later.